So this is a long list, and again, you don't have to memorize all these kind of things. This will all be in papers that we'll give you in the office, or you can find this online. So this slide is a comparison of the 3 different surgeries, the SADI, the bypass, and the sleeve. And in this order, it shows you what is best, what is good, and what is the least beneficial for the specific condition. So for weight loss, the initial weight loss, and the long-term weight loss, both of them. So weight loss overall, the SADI is the best. People will lose, on average, about 40% of their body weight. So if we come back to that person that I explained earlier, that a person who weighs 300 pounds, if that person loses with a SADI 40%, that's 120 pounds. So that 300-pound person will go down to 180 pounds. With the gastric bypass, on average, we'll lose about 100 pounds, so we'll go down to 200. And with the sleeve in the long term, a little bit less, so maybe 90 pounds. So that's kind of what we're looking at with weight. So with that new surgery, with the SADI, we will get patients much closer to a normal body weight. The SADI surgery is the best to treat diabetes patients, and it not only makes them less diabetic in the future, but it also regulates their blood sugar, so it's the most level and doesn't go up and down that it does with the other surgeries. This is what I meant by daily blood sugar stability, meaning the blood sugar doesn't go up and down, up and down, up and down. So the SADI is also good in terms of controlling other medical problems that come along with weight loss surgery. Because people lose the most weight, it'll also be the best in terms of treating the medical problems that go along with being overweight. In terms of reflux, a lot of patients have reflux when they have obesity. A little bit of reflux is usually not a problem. But if someone has really, really bad reflux, then the gastric bypass is the best surgery. And then the SADI, and then the sleeve. Sweet eaters. Some people just love sweets. So if a person loves to eat sweets but then has a gastric bypass or a SADI, they will get a condition sometimes which is called dumping syndrome. That means when they eat the sweets, an hour or 2 later, they will feel horrible. They feel like they're dying. It's a terrible feeling. Sometimes they have diarrhea, sometimes not. And it's nothing terrible. It's not dangerous. It just feels terrible. And it'll go away, and hopefully that person will never do that again. And we as surgeons, we think it's a great thing to have, because it makes you not eat the stuff that you shouldn't be eating in the first place. It's fair punishment, and you can avoid it by just not eating the chocolate, the cake, whatever has a lot of calories and a lot of sweets in them. Sometimes it happens with fat, if people eat like plain butter or plain whatever mayonnaise or something that has a lot of fat in it. So it's a good behavior modification tool if someone can't really stop eating sweets. For people who have a high body mass index, like 50, 60, for them the SADI is the better one because they will lose weight to a much lower weight, much healthier normal weight. In terms of how easy is the surgery, you might have guessed this from the slides earlier. The sleeve is obviously the easiest one, and then the bypass and the SADI are similar. In terms of recovery, it's similar for all of them. The recovery is really the same for all of them. Another issue that for some people is important is to have an endoscopy, to be able to have a normal endoscopy of the stomach. So with the SADI and with the bypass, we will cut through the intestines. So in that certain circumstance, particularly with the bypass, you can't look into the old stomach anymore. With the SADI, we will take out the rest of the stomach, but a person cannot have an endoscopy of the top part of the intestines anymore. So there's some limitations. It's very rarely that that is important for someone, but we take this into consideration. So any questions so far? Yes?
Why is the SADI better than the bypass if the SADI tends to leave you with a bigger stomach?
It's the malabsorption. So the question was, why is the SADI better than the gastric bypass when the stomach is bigger? Because this area that is bypassed here is longer. And when the food doesn't get absorbed, that's even more powerful than eating less. And surprisingly enough, that stomach is bigger, 2 or 3 times as big as with the gastric bypass, but it's still small enough that a person doesn't eat as much. So this is actually, this surgery is actually sometimes good for people when we know that they really have a hard time changing their habits, because sometimes some people actually can eat still some bad foods and still lose weight or keep the weight off. So not absorbing the calories is an important factor. All right, so every surgery has some risks, and I'll compare the SADI, the bypass, and the sleeve. So with the sleeve, the main risk in the long term is acid reflux. So with SADI, some people do get new acid reflux, even Barrett's esophagus, which is a rare but precancerous condition. And then they may need to go to have a gastric bypass. You just have to turn it over into a gastric bypass, and that'll cure the problem. So that's one of the risks of the sleeve. It's worse with just the sleeve alone. Is not so bad in patients who have the sleeve together with the SADI. The sleeve also has a the sleeve also has a slightly higher risk that the stomach stretches a little bit. So we've seen people now with the sleeve stomachs being 1 time or even 1.5 times or twice as big as when we made it initially. With the gastric bypass, there's a risk that there will be too much scar tissue in the area where we connect the stomach and the intestines right at the beginning. It only happens about 4, 5, 6 weeks after surgery. Then it needs some stretching. That does not really happen with the SADI and the sleeve. And the other risk with this is that with the gastric bypass, people can get ulcers in that same area where the small stomach connects to the intestines. And those ulcers can actually burst through, perforate, and cause sepsis and peritonitis. So that's something that we do not see with the SADI or the sleeve. And in that same area, where the stomach meets the intestines, is this area here. This is the area that's of concern. This is where you can have too much scar tissue. You need the stretching 4 to 6 weeks after surgery. This is the area that can cause ulcers. Or this is the area where people can develop ulcers, which can burst through, perforate. And this is also the area in the future where the connection that we make, which is initially as wide as my pinky, where that connection can stretch out to as wide as an inch almost. So that is a possibility. Then we can do more endoscopies, but these are all things that can happen, particularly in that area here. The other side effect that a person can get with a gastric bypass is a blockage in this area here, where these two pieces meet. This is not something that we usually see with the other surgeries, definitely not with the sleeve, and less so with the SADI in that area here. So there's a lot of considerations, as you can see, a lot of pros and cons and this and that and the other. So it's hard to make that decision which one. So I'm just going to introduce this all to you. These are all going to be papers that we have in the office. You can read on to this. We'll talk about this in the office. This is where you have your personal conversation with the physician when you're in the office. You can look through all this. You can compare all this with the physician. The physician can do it on an individual basis. They can look at your situation and say, well, you know what, for you this would be better, for you that would be better. This is how I usually do it. I mean, not one surgery fits all patients. So we talked about this thing called internal hernia. That's the blockage. I showed you that. The ulcer, I showed you that. And some people with a gastric bypass just have belly pains, and we'll never find the reason. They just always complain about pain in that area here. And we never find the reason why. We do surgeries, we do CAT scans, we do endoscopies, and they just have pain for a while. Most of the time it goes away, but it can last for months. And this only happens with a bypass. It doesn't happen with a sleeve, it doesn't happen with a SADI. On the downside for the SADI and then the bypass, people have a higher risk of getting low proteins, anemia, other nutrients, which these issues can be fixed with another surgery, but most of the time we just have to give people the appropriate supplements. With the SADI, the one big thing that differentiates from the other surgeries is people have more loose and frequent bowel movements. Sometimes with diarrhea, And usually people will tell them they have between 1 and 3 bowel movements a day. It's controllable, but it's different than what you experience right now. With the other surgeries, it's just the opposite. Constipation is the more frequent thing. And again, we look at each patient and say, well, this may be a problem for you, or this is just something that, well, you just deal with it because it's just what happens. And you get used to it. The SADI is also, if the complication of a leak happens, is more difficult. And I told you that the bypass and the sleeve have more constipation. So again, a lot of pros and cons and ifs and buts and things to consider, and it's confusing. But that's why we want to guide you through this and help you in the office. That's why when you make your appointment, mention all these things, and we'll steer you in the right direction a little bit. So this is the dumping syndrome I just mentioned earlier. When people eat sweets or fats, then they don't feel too good. It goes away. And I said, this is good behavior modification. This is something that some people actually want to get because they know otherwise they can't get rid of the chocolates.